Okay, well, today we have again Dr. Hudson Garrett, that is a member of our Norton Infectious Disease Institute. He's part of our team, and Hudson is, we are going to continue with the topic of healthcare associated infections, and then he's going to give us an overview of CUSP. Hudson?
Thank you very much, Dr. Ramirez, and thanks again for the invitation. Good to see so many familiar names. As Ruth will often remind everybody, I like to be outside of the box. I don't like to be inside of the box, and this really is a topic that is very much outside of the box, but I think one that is so critical for the topic of healthcare-associated infection prevention, and it's really what we call on the cusp, as Dr. Ramirez mentioned, and we're going to sort of walk through a quick introduction of this. I'm also going to give you some tools and resources at the end that you can leverage for different specific initiatives that you might have within your organization. So 3 basic things I want to make sure we cover today is, number 1, what in the world is CUSP, right? And how do we leverage it within sort of the utility of healthcare-associated infection prevention? Number 2 is, how can we use this from a risk mitigation standpoint? We know that a lot of issues with infections go back to communication and breakdowns therein. And so how can we leverage this? And lastly is, what do we need to do to get our healthcare leaders engaged, right? That is such a pivotal point that we have to work on, especially post-pandemic, where people are already burned out. We want to make sure that our healthcare leadership is actively engaged. So this is sort of a journey, and I'm going to make a little bit of a special offer that I didn't even tell Ruth about. But today we're really talking about sort of an orientation to CUSP and what it is and what it can be. But there's different components to essentially implementation of this project, right? There's sort of getting your team together. There's how do you engage your senior executive. There's the science of safety and sort of that team steps component. Then there's this thing called sense making, which is extremely cool, where we can actually look at identification of defects and risk mitigation strategies. And then lastly, we sort of bring it all together with this implementation framework around teamwork and communication. So if you're interested in trying to do this in your facility, I'll be willing to put something together that you can come to on your own. I'll record it. If you can't come to it live, I'll make sure it's available, and I'll share it with Dave so he can post it on the Institute website as well. So I'll work with them to get some dates out for that in case you're interested in trying to actually do this within your facility. But let's sort of start with the definition of what CUSP stands for. It stands for Comprehensive Unit-Based Safety Program. Now that sounds like a big name, but all it essentially means is go to the place where the work is done, which is the frontline clinical teams, and give them the tools, the resources, the autonomy, and frankly, the executive support to actually do the work correctly, right? What a novel concept, but we don't do this well in healthcare, especially here in the US. We also know that sometimes leaders don't have the necessary skill sets to even understand what is taking place at the front lines. And so this toolkit is a way to leverage your experience and expertise, both vertically in the organization, but frankly, also horizontally, where somebody might be at a manager level at the unit, and they can use this expertise throughout the organization. So there's a couple of different ways that we can use this, right? There's toolkits that allow us to target specific things like CLABSIs. There's ways that we can look at a larger context or lens like patient safety or healthcare quality. But one of my most favorite ways to use CUSP is to actually sort of flip the rocks upside down and find out what's really going on, right? It's that root cause analysis. Why do we continue to get so many CLABSIs? Why do we now have a lot of C. diff infections that are nosocomial? What's going on with all this MRSA in the community? Maybe you can target antibiotic stewardship as an example, and you'll see that CUSP has developed some specific toolkits, which I'll share the links with you at the end of today's program, and you can actually use those pretty immediately within your facility. So here's the components of the toolkit itself. What we're doing today is sort of going over that orientation, or what is CUSP, which is covered under the Learn About CUSP. The next different programs that I had mentioned would look at assembling the team, your senior executive engagement, how do I understand the science of safety, what can I do to identify defects, the implementation and teamwork, how do I apply CUSP, the role of the nurse manager at that frontline level, how do I spread the success and leverage that and learn throughout the organization, and what lastly can I do to engage my patients and my families, which is going to directly impact your HCAHPS scores in a positive way. Right? All of these are live links, so if you're interested after today's program in checking those out, you're welcome to do so. Like I said, I'll also try to put something together as a little live series that if you're interested in doing that, they'll be pretty short, and then we'll also record those and make those available for you. So CUSP is also built on our dear friend, the Cotter's 8 steps of change, right? Number one, create that sense of urgency, right? We don't do this well in healthcare, but we do it well with some things that are not important. We see this a lot with executive leaders in healthcare where they say, this is the most important thing for today. And you look around and you think, out of all the things that we should be doing in healthcare, this is by far not the most important thing that we should do, right? And so we want to make sure that we're identifying the most clear priorities that are going to have the biggest impact to reduce patient harm, improve patient safety, and frankly, also take the cost of care out of healthcare delivery. The second area that we're going to explore is, right, getting that guiding coalition. How do I get the right people sitting in the right seats on the bus at the board table, if you will, that can do the work and also support the work that needs to be done? Maybe you don't need an executive at the table. Maybe you need somebody who's a senior director that actually has a lot of power and influence. Or maybe you do need somebody at the executive table, like the CEO or the CFO, if you need financial resources. The third area is you've got to figure out, what can we all agree to do? And this is difficult, right? Even people you work with all the time, sometimes you may not be able to do this very well. And part of this is competing priorities and time management, but certainly sort of putting your individualism aside at the door and saying, how can we as a collective team do something together to positively impact our organization and the care in which we deliver? The fourth area is super difficult, which is to sort of outwardly communicate the vision, right? How do I go out and share with my frontline teams what I'm trying to accomplish? Now, think about the best boss you ever had in your career and the worst boss you've ever had in your career. I'm pretty willing to bet money that the best boss was probably one of the best communicators. The worst boss probably was terrible at communicating with you, right? We see this all the time, whether it's healthcare or any other industry, that the people that lead well are those that can communicate, those that are able to listen, and those that are able to be agile. The fifth area is that you need to let other people do their job. What a novel concept, right? If you're a leader, your job is to hire the very best people, to train them well, to give them the autonomy and the empowerment, and then let them loose, right? Now, certainly if we need to get involved at certain points, that's fine. But we want to let people have an opportunity to fail, because through failure, we allow people to learn. Now, I want to be careful in saying that I'm not saying let harm occur, right? If we can prevent harm, we certainly want to prevent that. But if there's a way that somebody can have a failure in a meeting or a presentation or, even data evaluation, and they can learn from that, let's allow them the opportunity to develop and blossom from that perspective. Step 6 is one that we are, lacking in healthcare, especially right now, which is short-term wins. And there's a lot of philosophy behind this in the psychological literature about, if you have big goals and you break them down into individual smaller goals, that if you check those, onesie twosies off every day, your momentum towards your final end outcome, right, is much more achievable, and you actually get better outcome, success, and really satisfaction from achieving that. The same can be true with healthcare-associated infections. Let's say that you're trying to reduce your CLABSI rate by 30%, and you start making incremental improvements every single month of 5%. And you get to your 6-month mark, and now you're down 30%, right? You're able to celebrate that every month, but you can really celebrate it when you get to that end goal, and then use that to sort of sustain yourself towards the future, because we know we can't ever take our foot off the pedal. The next one is consolidate gains and produce more change. So if we know something works in the ICU, the medical ICU, then let's learn from it. But if we did something that didn't work in the surgical ICU, let's learn equally from that as well, right? We want to combine those two things that are both working and those that didn't work, and combine those and share them with our organization so that people can either adapt those and figure out if there is some way to salvage them, or say, no, this is not a sort of pathway we want to continue to pursue. And lastly is probably the most difficult in my mind. And I've done a lot of work in this area about culture transformation. We know that if you want to truly transform culture, it absolutely has to start at the top. And it has to be anchored at the top by leadership. And a lot of leaders simply don't understand the science of patient safety. They don't understand the science of healthcare quality. They don't understand the science of infection prevention. And so we have to sometimes serve as an advisor, both to the board of directors for your organization, but also to the senior executive suite to let them know what this truly means. Right. And part of this is breaking it down into 3 different areas. And we've seen this a lot in the sort of context of just culture, the 3 buckets of human error, at-risk behavior, or reckless behavior. Right. Reckless behavior is you get behind the wheel of the car and you're driving knowingly drunk. Right. There is no excuse for that, that you're breaking the law, you're putting others at risk, you're putting your own life at risk, and you're knowingly causing potential harm. At risk is you fail to follow maximum barrier precautions because you don't have the time in your mind to do it, right? Whereas a human error is I inadvertently grabbed the wrong medication because it looked very similar and I administered it to the patient because I did not follow all of the safety systems or something fell through the cracks, right? So 3 different ways that we can look at this. Now, these systems are designed to hopefully, right? Hopefully is the key word, make sure that we manage the patient's experience well and that we prevent harm. But in many instances, we find that systems were not designed with that intent. They were not properly tested. It's almost like if you don't oil, the engine in your car, your engine's going to fall apart. If we don't continue to maintain the engine of healthcare, which is our people and our processes, then we're never able to maintain the success that we're going to achieve, especially with the reductions with healthcare associated infections. And a lot of this goes back to learning systems. The most recent data that's come out from CDC's NHSN also showed that during the pandemic, we saw pretty generalized, raises in sort of the data, if you will, for all of the healthcare associated infections. So all the rates went up, right? And that's not terribly surprising, I don't think. But what we're looking for is how do we get decreases that are both sustained, but also ones that we can figure out why they're sustained so that we can share that improvement science and then make sure we can leverage that across other parts of our organization or even other organizations within our health system, right? So part of CUSP is aligning with other things that you may have been involved with, right? We've certainly been exposed to team steps. Many of you that have done some of my programs have been exposed to that. You've probably been exposed somewhat to Six Sigma. There's the Institute for Healthcare Improvement, there's PDSA, we've got our RCA process and our FEMA, right? When we're looking at our failure modes effect analysis to really get to that root cause analysis. So the nice thing about CUSP is that if you've been exposed to any of these other things, it builds upon it. So you can take all of your knowledge and your experience with these tools and immediately leverage it within the CUSP model, right? And so it's very, very compatible with things like team steps. One of the things I like about team steps is that it allows you to break down those barriers in healthcare communication and prevent siloing, which we know kills patients. And it also kills relationships that we have within healthcare. And so this is an opportunity for us to use this to our advantage and bring some of these different tools together. Here's sort of another example of how we can leverage that as well. And with team steps, we can break down the barriers in communication by developing a plan that includes all the stakeholders, right? So if we're bringing everybody to the table, everybody's at the same dinner table, we communicate the message, we share what we're trying to accomplish, then we're able to go forward with a very comprehensive and integrated communication plan that includes the senior executive suite, which is going to always give us more bang for our buck if we think about it from that context. So here's sort of a provocative question, and it's a little bit specific to hospitals. But imagine if you're bringing your relative into your own facility. Now, maybe you don't work in a hospital. Maybe you work in a long-term care facility. Same question. Is your facility safe, right? Would you allow your own mother, your father, your child, your loved one, whoever it is, to be cared for at your facility? Now, I've asked this question to people before, and I get some interesting answers. Sometimes I get a very, very strong, adamant, absolutely. I feel 100% confident in the care that my facility provides. That's fantastic. I also get the flip side of that quite often where people say, probably not, right? And my question is if you knowingly have that answer, what are you doing about it, right? And people will often say, well, I'm only one person. And that's where CUSP comes in. It's that comprehensive unit-based, right, safety program that relies upon all of the people that are in the organization and in the unit to really drive that change. And so this is born out of the Agency for Healthcare Research and Quality, and it's been leveraged thousands of times across healthcare systems. And you'll see a couple of examples that I've included with the references at the end. But what's nice is that if you're an IP, it works great. If you're a patient safety manager, it's great for you. Healthcare quality, excellent. Nursing manager, medical director, it does not matter what your role or discipline is. It has something in it for you, because if you're practicing at the front lines, CUSP is going to bring that utility to your tool belt that's going to allow you to break down some of these challenges where we can't get to zero, where we can't get past reductions of 25%. But it also allows us to understand where the harm is coming from. And I think in a way, that's probably the most beneficial way. It's that diagnostic capability of understanding what's the true root cause of the harm or the reason for the underlying illness, if you will, within our systems that we have. And so Johns Hopkins has done a fair amount of work with this. They also teach a course on implementing this, specifically in the intensive care setting. There was also some data that came out years ago with the Michigan Keystone Center for Patient Safety that was exceptional, that looked at multitude of different hospitals, and that was furthered by the American Hospital Association, where they really looked at BSIs and CLABSIs, right? And so the nice thing about this, again, is that it doesn't matter what the sort of target area is, whether it's CAUTIs or CLABSIs or ventilator-associated events, whatever it is. You can use the model for any of those because it has fundamental principles that are fully transferable. That's what's really great about this. So let's talk about who you should leverage this with, right? Because the audience actually matters. Now, we've already covered the topic of senior executives. They are the folks that are going to really drive that culture. They're going to own that. And frankly, they should be the bulldozers that should move the obstacles out of the way for you. Don't expect them to do heavy lifting, though, for your meetings, because they should be there as sort of targeted resources. When you need them, use them. When you don't. But certainly engage them in the process. Our patient safety officers certainly play an instrumental role here because they own that culture of patient safety, but they also have sort of this vertical and horizontal role working with all the different team leaders throughout the organization to understand the root causes of patient safety. Probably the most important, though, is our frontline nursing managers that are managing the bulk of our team members, which is our registered nurses. And if we know what the real needs are here, right, and we understand the science of safety and how to leverage that at the bedside, and that nursing manager is sort of the keeper of that key to success, then we can really be looking at sustainable increases in patient outcomes, but also we can see removal of unnecessary patient harm and cost. The frontline staff are really our targets, right? But they're also our focus group. I think all too often we go to the wrong people to ask the questions. If you have a true question about how patient care is delivered, don't go to the nursing manager, right? Go to the frontline nurses that deliver the care. Go to the person that's working 3 or 4 12-hour shifts a week and say, Susie, how do you do this? What do you see? What's really going on here? Right, versus the person that may be the educator, the manager that's not providing direct patient care. And lastly, our physician champions and our providers, right? We know that they're excellent partners in making sure that we can both share knowledge, but also have a collegial relationship that's going to improve communication and also advocate at the end of the day for what is absolutely best for our patients, right? At the end of the day, that's what we've got to be there for. As far as implementation, there's a couple of different ways that CUSP allows us to do this. They've got some templates that are exceptional. Again, I'll provide the website that you can do this, and I'll also make some of these available in the future recordings as well. But they have different things that you can use. They've got videos, they've got checklists, which I particularly like. They've got some different articles. There's obviously a lot of information in the peer-reviewed literature as well. But some of the things that they strongly recommend is sort of that video-based testimonial from frontline staff members that people would recognize, right? That they're really speaking up on behalf of the patients and on behalf of the health system to say, this is what I did. This is how I was involved, right? To really share the success of that. It's almost like if you watch a non-custom healthcare video, and I'll just sort of pick on HealthStream for a minute because many of us use them. HealthStream's a great product and they have good stuff, but it's not customized. Right. And so you watch this and it's more of a compliance activity to get your annual competencies done. But imagine if you logged into HealthStream and every single slide was based on your facility. Every picture, every video, every policy, even the names were based on people that you actually knew. I think your sort of context and appreciation for doing that mandatory training would probably change because it would be a little bit more personal, right? And so as we implement projects like this, we want to make sure that it's highly personalized, individualized to the unit, and is really going to resonate with the target audience. Because we know that some of our challenges is how do I apply this and use this in units that may not think they need it? You know, NICU is a perfect example that they reference here because you may not have a ton of infections in that environment. Now, will you have infections? Absolutely. Sometimes you don't know you do, right? Because a lot of times you don't fully appreciate the burden of illness unless you really go looking for it. And that's certainly going to be a challenge. The other one that we're facing all right now, not just in healthcare, but just in general, is getting people to come to work. Right? We have this massive amount of staff turnover and frankly, just the ability to staff and recruit. And so this nursing empowerment piece may be completely devastated within many of our organizations. And lastly, is we've got to get our senior leaders engaged and participating in the process. So as we sort of define what the team is, we need to assemble the right people, right? What are the skill sets that I need? What are the principles that I'm trying to apply here? Do I need somebody that's really great with data? Do I need somebody who's really great with understanding culture or communication? Do I need a great IP? Do I need an executive? Do I need somebody who understands finances? Maybe I need the CFO or their designee. Am I going to need new products? Maybe I need somebody from value analysis as an example, right? And everybody needs to have a defined role so that we don't have all this misunderstanding during meetings about who's supposed to be doing what. And that's going to really help prevent all the barriers to team performance that we typically see when we don't have a good setup to the process, right? If I don't define what we're trying to do, if I don't stick to my agenda, if I don't allow people to speak up, it creates conflict. And while some conflict is good, we want conflict to be productive and to move the needle forward and to allow us to grow and develop new ideas. But when we don't have role clarity and we don't have good communication and respect, then we instantaneously break down the trust that is so fragile within healthcare. And a lot of this can be set by that relationship and that engagement with our senior executive, right? If we've got somebody sitting at the table that's a really good leader, that's extremely engaged, that's willing to engage in the process, to remove obstacles, say, I'm here to support, I'm here to listen, and I'm going to do what's necessary to make sure that you're successful as a team. But they expect you as the team to do the work, right? That's true leadership. You don't want them to jump in and do all the work because then the team doesn't get an opportunity to grow as a team together, right? Our whole goal is to create cross-functional groups of people that can solve problems, right? Imagine if we had 100 teams within a large healthcare system and then COVID hit, right? And all these teams have been working together for 10 years. Do you think COVID would have been a lot easier to manage because we already have these existing sort of SWAT teams? Absolutely, right? Do many of these organizations have these teams? Yes, they do have teams. Are they very functional? Probably not, right? And so we want to think about how do we repurpose the meetings that we have in the teams so that we can really get the best possible outcome. And a lot of executives don't have the necessary requisite background to understand what we're saying. So if you've got an executive that is not from a clinical background, that's fine. They have tools that in sort of skill sets and resources and expertise and perspectives that we don't have. Leverage that, but also share with them the necessary clinical acumen so that they can understand the picture that you're trying to paint, right? I am not a good artist. I appreciate good art, but I'm not somebody who can understand abstract art. So if I were to go to an art gallery, somebody would have to explain it to me. Right, I'd have to understand, right, what does that really mean that's on the canvas? The same is true here. We need to paint the executive the picture that we're trying to show them so that they can be involved in the process, let them feel the value of the process, and then also make sure that they're at a regular cadence. Now, don't waste their time and bring them to meetings where there's no value, but make sure that they're regularly visible. Another component of this, too, is that we have to understand the science of safety. If we don't have a fundamental understanding of this, then we have no capability of changing culture. We have no capability of improving quality, and we certainly cannot reduce or hopefully eliminate healthcare-associated infections that are mostly preventable. And so a lot of this goes back to understanding the team dynamics. right? We think about all the different stages of teams where they're forming, storming, norming, all those types of things. And if we don't have highly functional teams that have a good background of patient safety and the science of safety, then it can be difficult to really make sustainable incremental improvements. And this is why having your patient safety team, your project managers, those types of folks involved will be very helpful. Because when we look at this at the system level, right, there may be institutional, there may be individual facility like hospitals. Then we get down into sort of those departmental elements like the ICUs, the emergency department, the work environment itself. We've got to assess the team factors. How does the team perform? And then we have individual components, right? I worked with somebody years ago that was really brilliant, but she was a terrible team player. And it became so problematic that I had to let her go. And it was painful because she was a great person. She was very, very smart, but she just could not function at all within a team. And despite me trying multiple different ways to move her in the organization and giving her different opportunities, it was just not the right career for her. And so sometimes we have to think about that in that context, because at the end of the day, the thing that we're working around is not just our organizational characteristics, but also those of the patient themselves, right? And so a lot of this is recognizing that effective communication is going to drive compliance. It's going to also reduce those barriers to communication. And certainly there's a lot of data that supports when we do those two things well, that our rates of medical error and associated harm go way, way down, which is certainly our goal. Because a lot of the stuff that affects communication is stuff that we may or may not be able to control, right? Interruptions are very hard to control. Verbal abuse is becoming more and more common. We see this all the time. The amount of assaults that we see in healthcare just on a weekly basis is pretty astounding, right? To the point where you feel like you need to wear a bulletproof vest sometimes, right? You've got fatigue. I don't think that there's a day in the last 3 or 4 years that I've not felt fatigue. Each of you probably is the exact same way. You get up in the morning and you're like, well, my fatigue is about the same as it was yesterday, or maybe it's worse, or maybe it's a little bit less, and we always hope for a little bit less. And so we've got those particular barriers that are physical in nature and physiological. We may have people that change in the work environment. I got an email this morning about somebody I was working with on a pretty massive project, and she's no longer with the organization. And that is a huge blow because I had a lot of progress with this particular individual. And so those changes in dynamics with the team structure can negatively impact workflow. And so as you think about applying CUSP, I'm going to give you a couple suggestions here as we wrap up and see what questions you have, right? Think about where you would most benefit from this initiative. Think about how you can apply this within your culture, what needs to change within your culture, and then who can you recruit to your coalition of change, right? Who is somebody that you can put on your team that you have confidence wants to change, that has the ability to influence people? They don't have to have a title. They don't have to be a director, a manager, or VP, but they need to be able to influence people and bring them with you. Because a lot of this has been demonstrated in the literature, as I mentioned before. The Michigan piece, right? They saw massive changes in their data, right? Their climate survey results were big. They also saw some changes with their CLAPSI data. They've since done this with CAUTIES as well. So the point in sharing this is that this one data snapshot shows that it doesn't matter what the initiative is in terms of healthcare-associated infection, you can still make the change. The skill set, the model is fully transferable, which is really great that you don't have to change a lot of stuff. The other thing you'll see with this is not only improve HCAHPS scores with your patients, but your staff is going to be happier, right? I don't remember the last time I talked to a nurse, especially, that said, I'm so happy at my job. I don't ever hear that anymore, right? And that's not just the COVID-19 pandemic, it's everything else, is workplace violence and all the other stuff we're dealing with, right? But we know that there are changes in the organizations that need to be made. There's changes in staffing that need to be made, but we don't have a lot of luxury of doing those things when we don't have a pool of people that are able to step in and take on some of that work. But one of the most important things with CUSP that's also shared with Team Steps is getting on that shared mental model, that we're all committed to doing the same thing. I've only actually really achieved this with one single person, and she's going to kill me for singling her out, but it's Ruth Carrico. I have never worked with an individual in my professional career ever that I have ever been able to achieve this with other than her. There are times where we can either be presenting or be in a conversation, and I can literally understand exactly what she's about to say next, and likely she can probably feel the same way about me. But we share this shared mental model of improving patient safety, reducing harm, taking costs out of healthcare, and improving the quality of care. And it is completely obvious when we speak together. And that's something that I find is a blessing. And so when you find those people in your career or your organization, hold on to them tight, right? Go out and clone them, create more mini-me's, right? So that you can leverage some of the success. One of the other things I wanted to share with you as we wrap up is please, please, please think about the target audience in the C-suite, right? That executive suite. The very best place I can recommend that you could go to both get involved, but also get educated and informed is the American College of Healthcare Executives. I've included the link there at the very bottom left, and so we'll share the slides, and that's a live link for you. The Learning Center is where I would go. I believe to join, it's about $225, if I'm not mistaken. That's what it was, I believe, when I renewed. But this is by far the most influential group of executive leaders that you'll go to. Their conference, I learned from more than any other conference I go to. It's not a clinical conference, but it is by far the most varied experience that you can get to learn about what's truly taking place in healthcare. It is not uncommon for you to see healthcare systems have complete tables of their entire executive suite. The chief executive officer, chief operations officer, nursing, medical, financial, supply chain, everybody sitting at the same table. We need to be able to speak the verbiage that they do, just like they need to understand our clinical acumen as well. So these are the additional CUSP toolkits that are specific to different HAI initiatives that I wanted to share with you. As promised, you can see them listed here. These are live links. So when you click these on the slide, it'll take you directly to that particular link. There's two more that I'll show you here in a second. I know a couple of you I recognize are from long-term care. So you'll notice that there are some there at the end that you can use for long-term care as well. And then lastly is these are two projects that they have ongoing. I know one of the great pieces of work that's being done by the training center is on antibiotic stewardship. And so I'd encourage you to check out this program as well for improving antibiotic use. We know that that's a big problem. It's one that has a community impact, and certainly post-op surgical care and recovery is another one that has a lot of correlation directly back with infection prevention as well. So these are, again, live links that are available. These are ongoing CUSP projects with AHRQ. So you'll notice that the tools and resources will continuously get updated as they develop new ones. So just a quick summary, right? We know that CUSP is one of those tools that has so much ability to be leveraged in a variety of different circumstances. You can use this in terms of staff development. You can use this in terms of quality initiative or continuous quality improvement. I would strongly encourage you, if you are an accredited organization with Joint Commission, HHC, DNV, or if you're CMS regulated, which we all are, share this with surveyors, share with them what you're doing as part of your commitment to patient safety, right? Use that as that sort of element. The other piece to this too is that we know if we eliminate bad communication and we break down silos, then we can get to the root cause of most of the cause of errors, right? And when we understand why something is happening, then it allows us an opportunity to fix it, right? And that's really the true improvement science that we're trying to achieve. Our goal should be to get to zero patient harm, zero healthcare associated infections, zero medication errors, whatever it may be, zero patient falls. But we can't do that if we don't understand why these things continue to happen. And lastly is use this as a tool to go across your whole organization. It's a great tool for you to create visibility for yourself. It's also a great tool for you to bring people together with the shared goal of, really achieving that triple aim of Institute of Healthcare Improvement. How do we take costs out of healthcare? How do we improve the overall quality of care and make sure that the patient's experience is going to be as stellar as possible? Here's some additional tools and resources in case you're interested. These are also live links as well. And then I'll also share my contact information. There's also the link to the training center, which Dave posted in the chat. And it looks like Dr. Carrico also posted the web link for the toolkit as well. So with that, Ruth, I'll turn it back over to you and Dr. Ramirez for any closing comments and see what questions we have.
Thanks, Hudson. I want to just kind of reinforce what a couple of things that you said, that at the last year's SHEA conference, the Infection Control Canada, ICANN, Chica, APIC, all of the organizations are pushing this element where we may know what we need to do to prevent healthcare associated infection, but the challenge is always, how do you get it done? And that oftentimes the infection preventionist is viewed as the one who is responsible for infection prevention and control, but we recognize we are not the ones that are doing the work. So our role is, how do we lead change? How do we make this happen? How do we work with teams? How do we encourage and facilitate this type of interactive work? And so this whole subject matter is getting a lot of attention now on how it can be done and what are some of the the basic tools and how do we improve our abilities to do this. So what you have mentioned and the resources that you have given us are of tremendous value. And I think when you look at all of the things that we need to do based upon your experience and the number of interactions that you have had just across healthcare and across industry and so forth, what do you see as some of the biggest challenges with infection preventionists and kind of beginning to help put this into action, put this change into action?
This may sound completely basic and elementary, but I think people want to know we care. And I think that's both true for the profession and true for the patient. If you as an infection preventionist are not beat down right now, then you're probably living in some type of bubble that I'd like to figure out how to get inside. I think we're all beat down, right? Everybody in healthcare is beat down and in some way demolished, given the pandemic, the staffing challenges, all of those types of things. But if you knew that your leadership was fully behind you, and you knew that there was good communication and great listening coming from above, and you knew that there was support that was taking place, and you knew that there was a light at the end of the tunnel, many of us would probably stick it out. That's not what we're seeing across our organizations in healthcare. I've yet to see, even at a federal level, any type of debrief or postmortem for COVID that says, these are the things that we did well. These are the things that we didn't do so well. Here's the things that we want to do better next time. I think without that level of visibility, it's hard for us to have a lot of confidence that if something else were to come along in our journey, which we know it will, that it would be better handled. And I think our vulnerability is very high, which is, I think, why this type of program is so critically important. And I think from a patient perspective is that patients want to know their healthcare provider truly and genuinely cares about their outcome. It is very, very rare for the infection preventionist, unfortunately, to be able to visit with individual patients. And we understand the reasons for that, right? There's the timing and all that type of stuff. And maybe you don't even get an alert until the patient's already discharged. But imagine if you had an interaction, just like you were admitted to a unit, where the infection preventionist or a designee, right? Maybe it's somebody on the unit that's an infection prevention advocate, comes in and says, these are the things that we're going to do to make sure we make your stay safe. And here's what we'd like you to do and your family to do to try to stay safe as well, because we're your partner in your care. I think we would see a change in attitudes, and I think we would see a difference in the partnership, both at the unit level as well as with the patients.
Maybe how to convey that message to our departments, that that's something they need to take to, or how can they take that message. Any questions from those in our audience, those in the chat, or you can always unmute yourself and ask a question. And if not, Dr. Ramirez, do you have any questions or comments? Anything that you want to add?
It's interesting that again, because as you were doing this presentation, you already mentioned that we go from the organizational level to the hospital, and then you ended in the unit. You ended at the core. We are changing. It's almost like in economic, we are changing from globalization to localization. Everything needs to be at the local level. Then this is, but sometimes creating the team to have this teamwork. We have the great possibility here that we are developing the team. then we are building a team. We always mention the team is the most important aspect of whatever we're doing. But sometimes you go to work in a place in the hospital, in this particular unit, and the people are already there, and this is your team.
Right.
And then someone is working on the team, and as you mentioned, there are so many problems that people have outside, and then people bring the problem inside, and you have conflict, personality conflict inside of the team, and you don't have the possibility to say, okay, well, I want, as you alluded, okay, you don't work, we are going to move you. Then one advice for resolving this idea of personal conflict with a team when the people need to continue working together. There's not a possibility to move people around, because sometimes in healthcare you are quote unquote stuck with your team. As you
I would say the first thing to do is to figure out what your baseline is, right? And at the end of the day, yes, everyone is a part of the team, but not everybody has to be a part of the change management team, right? And so you may have sort of two different levels. And at the end of the day, you know, despite what we say about staffing, if I have somebody that is causing harm, right, they have to go. If I have someone who is not willing to stop potentially causing patient harm, they have to go. If I have somebody that's willing to learn, I'm willing to teach. And I think that's the biggest issue to your question, Dr. Ramirez, about how do I make sure that these are individuals that are willing to even be a part of the process. And if they're not, that's where it can get pretty challenging from a human resources standpoint. But I'm a big believer in, if you create a groundswell of peer pressure and you show them what's possible and you give them a win, and allow them an opportunity to be a part of that win, you typically see a lot of resistors become more, you know, game players. They will typically get on board a little bit more than they will continue to resist. Now, there'll always be the outliers, of course, but I have pretty good experience with bringing people along with you. Now, do they stay long-term? Potentially not, and that's fine. Because my goal is to not make sure that you have a long-term career with me. My goal is to make sure you have a great career taking care of patients and doing it the right way. So I think it depends on what your objective is. But if you have to work with the team, figure out if you can mold the clay. If you can't mold the clay, then figure out if you want to keep the clay. Right, is probably the best, I guess, advice I can give in the most basic sense.
Very good. As always, Hudson, it's a pleasure to your presentations and your insights on the questions and answers. Ruth, you want to close?
Sure. Again, I appreciate it very much. Thank you, Hudson. This is such an important issue, and it's relevant to patient care. It's relevant to us as we look at research. How do we build teams? How do we, make this happen? How do we get the desired outcomes? And we realize it's not simple. So thank you for spending the time with us today, and we look forward to next week. And again, this recording will be up on YouTube. Give Zed a couple of days, and he usually has it up there very quickly. Next week we'll be coming back to a microbiology topic. So we will have Dr. Alan Junkins with us next week, and we will see everyone then.
Thank you. Thank you, Hudson.
Thank you.